Hi, good morning, everyone. I think today we have a lot of smiles on the faces. We are completing 100. We are celebrating 100th anniversary for National Medical Association's a program that was started by Dr. K.K. Agarwal, who was the past national president of CMAAO. And his dream was to bring all the roundtable think tank people across the world come together and help the world for pandemic. Unfortunately, we do not have him with us, but I would say he's still with us. And this platform has gone to a next stage. We have a lot of people joining in from the world and helping to gain knowledges for all the medical association. This is no longer a medical association forum meetings. This is a knowledge where a lot of people come and share on this platform. We gain from this knowledge. We understand what is happening in the pandemic in each country. We follow the processes. We make changes whatever we can, and we move forward. This is one of its kind. And today, we are celebrating the 100th episode of this session. We have an important topic, but before we can invite the speaker, I would like to introduce, we have World Medical Association President, Dr. Heidi Statesman. We have CMAAO President, Dr. Tai Chun. We have CMAAO Chair, Dr. Chong. And we have about 19 to 20 countries over here participating in this forum. I would like to invite Dr. Heidi to speak the opening remarks from World Medical Association. Dr. Heidi.
So, hello everyone, and congratulations to your 100, or our, maybe I could say 100 meeting. It's impressive how this has been established and has continued to live, and keeping a very high quality of the meetings. This meeting has connected the physicians all over the world, not only in the CMAAO, and also me, before I became president, follow the meetings. Connecting the world in collaboration is keystones in medicine. It has helped us a lot during the pandemic. We could share knowledge faster than ever and help each other, and also spread knowledge around the world to help healthcare. And I'm very happy that this continues, and I hope that it will be established as a permanent meeting, and maybe developed into other forms as well in the future. I see that it is challenging times, but for the medical professions, challenging times is every time for us. That's our profession, to take on new challenges, to develop cures, and to help, even if we can't cure, and help each other. And a professional network, it is today the way we work. So I'm very happy to attend today. Thank you.
Can I invite the president for CMAAO and the president of Taiwan Medical Association for the opening remarks?
Oh, it's nice. So our vision is back on screen. Let's welcome for President Cho for the remarks.
Thank you very much. Dr. Heidi, President of WMAA, Dr. Chung, our CMAAO Chair of Council, Dr. Mashuder, our invited speaker, Dr. Sarab, and all distinguished presents and colleagues from CMAAO. Good morning and good afternoon. Today is the 100th of our CMAAO International Weekly Meeting, which marks the 2 years fighting against the COVID in this region. Starting from 2020, with totally ignorance, we slowly but steadily gained understanding about the virus and how it spreads. We developed vaccine and the treatment. We mobilized our healthcare workforce and the delivery systems. Our economics preserved, then rejuvenated. We educated our citizens the importance of vaccination. Now, more and more countries and regions are losing restrictions such as social isolations and mask mandated. During our many weekly meetings, we gather the collective wisdom and insights from every national medical association to develop advisories and guidelines and contribute to restoring the health of the global society. We are all grateful to the founder of this conference, Dr. K.K. Agawa, our past president of CMAAO. We remember his passion and idealism fighting the pandemic, and he made the ultimate sacrifice. He will remain in our hearts through this conference. One of his many enduring legacies, we will find a way out, no matter how many times the virus mutates. I would like to express my deepest gratitude to everyone in CMAAO. Let us work together and fight with the well-being of our region and the whole world. My sincere thanks to all speakers and the participants, and I wish today's meeting a great success. Thank you very much.
Thank you, President. And I would like you to also be a part of all the future events which we are doing. This is a very, very emotional and a very close moment for us. And we formally would like you to chair the sessions going forward also with Dr. Chong and with we hosting these sessions. So thank you so much for being with us right now. Can I invite Dr. Chong, the chair, for his opening remarks? And he has been with us since I think the first session, if I'm not wrong.
Thank you, Saurabh. Thank you very much. And Dr. Heidi Stens-Marin, my president, President Chui, Tai Yuan from Taiwan, my chair, Dr. Koh Katai, my vice chair, sorry. And Alvin isn't around, but I'm sure he'll join us later, our treasurer. And it's good to see everybody here today. And this has been a long journey. It's almost 2 years now since we started these sessions under the great guidance and leadership of Dr. K.K. Agawa. And it is in his spirit and his that we have carried on these sessions faithfully, week after week after week. And we've learned so much. We've had so much comradeship, camaraderie, and we've learned so much from each other. And we've managed to also attract a number of notable speakers from across the world. And, the amount of knowledge I've gained from these sessions over the 100 weeks is incredible. I mean, we have perspectives from all over the world, and not just our 19 nations in CMAAO, but we also had excellent feedback from USA through Monica and her colleagues. And, Dr. Kuzi and Dr. Akhtar from South Africa. Dr. Deborah, I hope she can join us today from Brazil. And, it's amazing. I mean, such a privilege, such an honor to be here week after week after week with all of you. And certainly looking forward to seeing all of you in person in September in Karachi this year. And without much ado, let's welcome Monica. And she's such a great speaker. We always welcome listening to her. Thank you very much. And all those who have attended today, thank you very much. And we look forward to hearing from Monica. Thanks.
So before Monica can join in, and I would just like to highlight one discussion with Dr. KK, which I had in the first or the second CMAAO meeting, and I said there are not many people joining, and like it was like 7 sessions already, and there were 2-3 sessions which have been concluded. And I said there are not many people joining in. So do you like really like do you really want me to work on it, or do you want us to do something change? He says knowledge is something which everybody will come and gain. If you give knowledge, people will definitely come in and take the knowledge. Today, not many people are joining in, but I think my focus is that all national associations come on the same platform and don't talk about any politics, only talk about knowledge. Trust me, it will happen. And we are sitting on the 100th session, and we are having all the, I think even the WHO has joined on this forum, people from Johns Hopkins, Harvard University, all big, Mayo Clinic, all these people, big people have come and shared their knowledge, and they have blessed, and they have come at the odd hours as well. I think the most difficult part was to bring everyone on the same timing, because as you mentioned, Brazil, it's like 3 a.m. We have Heidi today at 4 a.m., and they're all looking fresh. So this is a, this is a benefit we took over for being a virtual, and we are continuing with this session. Over to you, Dr. Monica. Dr. Monica is immunologist from USA. She's also related to Dr. KK, and she has given her time for CMAAO, unconditional, giving knowledge, and she has a lot of publications and research in her name. Without more introduction, we all know Dr. Monica. I would like to invite her.
Thank you, everyone, for a incredible introduction. I'm very humbled and feel also very humbled to be here today. I would like to thank Dr. Stensmeieren, being 4 a.m. and beyond that now, Dr. Tai-Chan Chu and Dr. Chong for your very gracious introduction today. I'd like to talk today about moving forward, but by looking back. And by looking back, I mean the centennial experience that we've had in being together, some of us for some of the meetings, others for a few more. But I think as summarized by all our introductions, this is a forum. It's a forum to share our knowledge, to share our experiences, and that under the umbrella of Dr. KK Agarwal, who had the vision of what we're experiencing today. And it is also a very poignant time in a very geopolitical state of disarray for a lot of countries, and understanding how healthcare and medicine, how we transcend all of those geopolitical conflicts and think only about health and care, and understanding that we're at a crossroads when it comes to this pandemic and what we're seeing happening in the world today. So all began with Dr. KK Agarwal's vision, and his legacy lives through all of us today. And he was an influencer, a positive influencer of healthcare. His vision was to provide the greatest healthcare to the greatest number of people and to leave a lasting impact. And we can see that today. I'd like to start by talking about the origin of the pandemic in which we are living. This is a recent publication that's a study in preprint, which is a geospatial analysis that was conducted by researchers looking at the southwestern section of the Hunan market, where live animals were sold as recent as 2019. And this area was seen as the potential epicenter of the outbreak. The researchers looked at the first COVID-19 cases in China that were found during the WHO investigation from newspaper articles and audio and video recordings of doctors and patients in Wuhan. They found from 156 cases in December of 2019 that they were tightly clustered around the market, with cases gradually becoming more dispersed across Wuhan during January and February of 2020, as you can see along these 3 panels. This is one of several publications that have come recently to describe the origins of this pandemic. And it's important to understand the origins so as to prevent and to understand future pandemics which may arise. Now, looking at the pandemic as we have seen it, we are looking at here a diagram of fatality rate on the y-axis versus people infected by each sick person, or the communicability of each virus on the y-axis. And what you're seeing here is in relation the 4 different variants: the ancestral strain that is in the light blue, the alpha strain that is in the little bit darker blue, the delta in the darkest blue, and the Omicron, which is either navy blue or black. And showing that Omicron has been the most infectious, but the fatality rate is lower. And then it's showing you the SARS-CoV-2 virus in relationship to the bird flu or Ebola that you can see had high fatality rate, and the very highly infectious measles. So it's always good to understand where are these viruses in relationship to the viruses that we have understood in our prior experience and in our training. To also understand where we are in this pandemic and how this has been an incredible example of vaccination innovation. And what you are seeing are the highly effective and safe vaccines that have achieved the highest velocity in history. It took 10 months from having the sequence of SARS-CoV-2 to development of mRNA vaccines and completion of large-scale trials with 70,000 participants, with no less than 95% efficacy against symptomatic infections at the time that they were made available. And you can see here with malaria that it started in development in 1880 and it continues in development all the way to COVID-19 at the bottom, where you're seeing, where you can see the smallest bar is on the side. And that is at the bottom. This is a graphic that was put forward by Eric Topol, and this is on his Twitter feed. And you can see here the first documented case of COVID-19 illness on December 1st, unpublicized was November 17th, to the availability of phase 1A vaccination for healthcare professionals in the United States and in Europe in December. And what you can see here is December 1st, you have your illness. January 10th, you have the SARS-CoV-2 virus sequenced. You start having collaborations with the NIH and Moderna. You have the beginning of phase 1 and 2 trials by March. That was 2 years ago. The Pfizer-BioNTech trial begins May 2nd. And then you can see how they then enter into phase 3 trials. You can see how the participants have been included, showing efficacy by November of that year. And then you have submission of the emergency use authorization by the end of the year prior to the use of these vaccines. Where are we today in terms of cases and deaths per 100 million people? So everyone is familiar with the Our World in Data graphs. At the top, you see the new cases per 1 million. And at the bottom, you see the new deaths per 1 million. And you can see the 4 different surges very clearly in the bottom graph with the new deaths. The most number of cases you are seeing at the end is representative of the Omicron variant. And you can see that the numbers are going up and then going down. And what is not being represented here, though, is Hong Kong, which you can see here, which is still unfortunately on a vertical up trajectory. We expect these numbers to change, obviously, but this is the snapshot of today. Information related to the pandemic is rapidly changing. As I speak about this, I am sure within the next 48 to 72 hours, we will start seeing new information. We have paid a heavy toll with this pandemic. And this is representing US data. A quick Google search about the death toll related to the COVID-19 pandemic has shown that we are almost approaching 1 million lost lives as a result of this pandemic. What you see here on the right is a memorial in front of the Washington Mall. Each of these flags, white flags, representing a life lost. We have seen the appearance of these vaccinations as a way to address and to prevent these lives lost. And we can see the uptake of vaccinations per 100,000 people from December of 2020 until now. And these are representative of some of the countries in terms of their vaccination. I've spoken on many occasions about the efficacy of vaccination in preventing severe illness, hospitalizations, and death. And this is just one illustrative example in children that I decided to show today in ages 5 to 17 against Omicron and Delta and protecting against hospitalization. It's breaking the data up in age groups of 5 to 11, 12 to 15, and 16 to 17. What you are seeing are those that are positive in cases in the middle column. And on the extreme right is the vaccine efficacy. And what you are seeing is that the vaccine efficacy is high in those who receive 2 doses within 149 days after the second dose, and the efficacy is seen to drop after the 150 days after the second dose. Again, one of many different examples of showing you the efficacy of these vaccinations. We didn't talk a lot about the efficacy of natural infection, and this was a study that was recently published in the New England Journal of Medicine. And this was a sero-epidemiological study, which was a survey of over 7,000 individuals in Gauteng province, South Africa. And this was before the Omicron variant outcompeted the Delta strain. That this study showed that 80% of those aged 50 and older, and this is represented here in this bottom graph, had antibodies against the virus with seropositivity that was likely generated by prior infection. The researchers thought that this decoupling of incidence of COVID-19 cases from the incidences of hospitalization and death during the Omicron dominant wave heralded a turning point in the COVID-19 pandemic. If the primary goal is protection against severe disease and death rather than prevention of infection, the 70% vaccine effectiveness against the severe disease with Pfizer vaccine in South Africa might have been due to the hybrid cell-mediated immunity induced by vaccination and natural infection. And these are all topics in terms of developing that community immunity. How are we developing immunity? Infection versus immunization. Do we consider a prior infection as like one dose of a vaccination? But I think all of this is going to come into play when it comes to moving from a pandemic to an endemic phase. And this was a very elegant graphic by Shane Crotty that was published earlier. And I had shared this in an earlier presentation talking about this concept of hybrid immunity. And this is when you combine natural immunity with vaccine generated immunity. So what you see here is that if you have natural infection followed by vaccine immunity, you get a larger than expected immune response. And this could be seen as a result in 25 to 100 times higher antibody response that is driven by memory B cells and CD4 T cells that can show broad immunity from variants. When we talk about the immunity, we also talk about the different types of vaccines that have been available. And it's very interesting to come back to the slide that I had shown almost a year ago, talking about the different platforms where some of these vaccines were not even available when this graphic was developed. And we can see today that of all these contenders of these different vaccines that use different platforms, how many of these are in use today? We have become very familiar with the mRNA vaccines from Pfizer and Moderna, the inactivated vaccines from Sinopharm and Sinovac. We have seen the AstraZeneca vaccine being ubiquitously available. We are hearing about Novovax that's been available in Australia, certain other countries, and is actually up for EUA in the United States, and we expect it to be available potentially in May. So we come back to the slide that we're continuously assessing and making vaccines available and helping to address the different mechanisms, the different platforms, and to be able to continue to build the world community immunity. When we're talking about this sense of community immunity, how are we going to move forward from this pandemic? We have to understand what have been the factors that have made an improvement or had a negative effect on vaccine effectiveness on both either the individual or the population level. And what you see here is a graphic of different host factors, demographic factors, vaccine access factor, immune factors, and viral variant factors that can lead to a change in vaccine effectiveness. So for example, in the host, if you're older age, if you're immune compromised, or if you have underlying health conditions, this will have a negative effect on vaccine effectiveness. But that concept of hybrid immunity, where you've had prior infection and you follow it up with the immunization, then you will have better immunity. Genetic polymorphisms, changes in our genetic being in terms of how we respond can have a positive or a negative effect. What about demographic factors? If you have high levels of vaccine uptake in a community, you have high levels of herd immunity, that's going to have a positive effect. But if you have people that live close together, or you have a high level of circulating virus and you're in a local surge, that's going to cause decrease in vaccine effectiveness. The vaccine access factors, which vaccines are used, how many doses are you getting, what is the timing between doses? We've seen a lot of literature, a lot of information coming from different countries and their approach to vaccine doses as they were addressing access to vaccines. Also, limited access to vaccines will all decrease the ability for the vaccines to do its job. We heard a lot about the heterologous prime boost, about the studies that were done to show using one vaccine from one platform followed by another vaccine from another platform. We talked about viral vectors followed by mRNA vaccine having a very high success rate. And we talked about cost-benefit decisions by national vaccine bodies to be able to help improve vaccine uptake. So behind me, the immune factors graph says high antibody titers, quality of antibody, and as being effective and positive effect, and of T cells being unsure. And then finally, the viral variant factors. If your vaccine does not protect you against the antigenic determinants of the virus, then your vaccine's not going to be effective. Or if you have an increased transmissibility of the vaccine, so the vaccine is able to be faster than the ability for the immune system to respond, then of course, these are factors that need to be considered in terms of achieving that community or herd immunity. Now, there's a lot in this slide, and it's a summary to talk about our approach to those who do get sick. What do we have available? This graph and graphic will change accordingly to the availability of medications and whether or not these medications have been shown to be effective against a circulating strain. So we have those that are healthy, who have mild to moderate disease. We have the availability of replication inhibitors, remdesivir, molnupiravir, the Paxlovid. We have not neutralizing monoclonal antibodies. I understand that access to these monoclonal antibodies are not ubiquitous. Even within the US, we do not have availability of all of these antibodies even for those patients that we would like to have them for, and we're having to use a triage and prioritizing approach. We have immunomodulatory therapies such as dexamethasone and repurposed rheumatological drugs to help with the immune storm that happens as a result of infection. And then we have adjunctive therapies such as anticoagulation and NSAIDs. And in this recovery phase, we are really going to face a lot when it comes to the long COVID that we are going to experience as we move to the next stage of this pandemic. The burden of this pandemic has been tremendous. And this was one of many different types of burdens that we have seen as a result of this pandemic. And this caught my eye. We have seen, this was published in October. This is before the Omicron surge, that 140,000 US children lost a primary or secondary caregiver due to the COVID-19 pandemic. We are going to face unprecedented downstream issues related to the pandemic, whether it be mental health, whether it be restructuring of our healthcare system as a result of the pandemic. We are seeing a mental health epidemic during this pandemic and will continue following the pandemic. We have all absorbed stress at a level that has been unheard of before. We've had stressors before in healthcare. We're all used to this. We're all trained for this, but none of us were trained for the sheer amount and high level of consistent stress that we had faced during this pandemic. And as healthcare providers, as healthcare administrators, we all need to take care of each other and to acknowledge the fact that this is all going to have an impact on us as we enter the next stage. There is no new normal. What are some of the long COVID symptoms and signs? And I like this graphic because it is showing you what happens in those who suffer from long COVID, in those who were hospitalized during the acute phase versus those who were not hospitalized during the acute phase. You can have neurological or neuromuscular symptoms such as headache and tremors, musculoskeletal, such as muscle pain, joint pain, and impaired mobility. We're seeing that there's a cluster of gastrointestinal symptoms such as nausea, vomiting, diarrhea. You have systemic symptoms such as fatigue and weakness. I think that's very common. We all hear about this. Neurocognitive, memory impairment, brain fog. How many of us have heard brain fog from our patients? Psychological and social, the anxiety, the upper respiratory sore throat, nasal congestion, cardiopulmonary, and other. And what you can see between both these two groups of people is that you are seeing that all of these systems are being affected in those who've been hospitalized or not been hospitalized. And we continue to need to have more research on this. This is a recent publication that came out of Cell looking at more detail at the specifics related to long COVID, which is also known as post-acute sequelae of COVID-19. And you can see that patients who experience this have had associated comorbidities such as type 2 diabetes. They had viremia with SARS-CoV-2 and the presence of Epstein-Barr viremia with the reactivation of latent viruses, and they had specific autoantibodies. People with GI symptoms as part of their long COVID presentation, they had newly expanded cytotoxic CD8 cells and CD4 positive T cells, including those of a specific SARS-CoV-2 clonotype. A lot more information is coming out. A lot more information will continue to come out regarding post-COVID. And I think long COVID, I think this is going to be a big area that, of course, we are all going to need to be trained on in terms of recognizing it and understanding ways to address this. In terms of vaccinations, the United States is ranked 67th in the world for being fully vaccinated and 54th in the world for receiving a booster dose. This is showing you a graph of those who are fully vaccinated across the world, where the darker the green, the more vaccinated you are, and the darker the brownish orange color, the least vaccinated you are. We have a long way to go to get that level of community immunity that we are seeking for just based on vaccination. This is the picture, and I like to show this because this is a graphic showing where there's high levels of community spread in orange, low community spread in green, and medium community spread in yellow. This is February 24th on the left and March 3rd on the right. We are moving in the United States to levels that are now considered to be in a level where we can be safer. The spread has continued to be lower, and that we can now address being in society, being unmasked. And we have new guidance related to this. And we understand that this graphic will look different, not only by time, but also by geographic location. This is a new guidance that has come from the CDC as being low, medium, or high based on hospital beds being used, hospital admissions, total number of new cases per 100,000 people in that area. So those were the three colors that I had shown you in the prior map. So if you live in a low risk county, which now represents 90% of the country, we can wear a mask based on our personal preference and informed by your personal level of risk. Right now in the healthcare facilities, we are wearing masks, and we're starting to see the unmasking approach across multiple different places, whether it be schools, whether it be sporting venues, and whether it be other private businesses. And you can see if you live in a medium risk county, then discuss with your healthcare provider if you need to wear a mask and take precautions. And then if you live in a high risk county, then to wear a well-fitted mask. We had our State of the Union address on March the 1st, and President Biden went through his list of coming back to normal. What he showed was, or what he delineated was, keeping businesses and schools open as a priority, improving access to testing and treatment, using this approach of test to treat, which is to expand access to antiviral pills and other COVID-19 treatments, one-stop sites to receive treatment for COVID-19 immediately after testing positive. So if we go into a retail pharmacy, we get a test for COVID, we get a result for that test, and if positive, we have the ability to be dispensed the medication so as to have testing and treatment occurring in the same place. They want this to happen in local pharmacy clinics, community health centers, long-term care facilities, and veteran health facilities. We are having issues related to the access to some of these medications right now, but this has been made a priority. They need more funding for vaccines, antiviral treatments, and continued vaccine research, wastewater surveillance that tracks cases by collecting and analyzing fecal matter from community wastewater, genomic sequencing efforts, and to address long COVID and mental health. And some of these concepts I'm going to go through in a little bit more detail. What does it mean to move from pandemic to endemic? What you can see is that the path to becoming endemic requires becoming endemic on an individual level, on an epidemiological level, and an economic level. So on an individual level, this occurs when the fluctuations in the disease burden cause only minimal change in people's economic and social behavior. Are we not going shopping? Are we not going to school? Are we not going to work? On an epidemiological level, this occurs when COVID-19 at a predictable level and does not require society-defining interventions. Are we told to stay at home? Are we told to wear masks as a mandate? And then the economic endemicity occurs when epidemiological substantially decouples from the economic activity after secondary economic impacts are largely resolved. So how is it that we go back to being financially independent of the pandemic? At this point, we are rolling back public health restrictions, and we're starting to see the inertial stages of moving to endemicity. So what does the future hold? And this was a conversation on an earlier CMAAO platform where we talked about pan-virus vaccines. can we get the information that we know about conserved areas related to all the different variants of the SARS-CoV-2 virus and use those areas as targets for a pan-virus vaccine? So what you see here is that antibody A broadly neutralizes a binding site, and it can block multiple related viruses. However, in antibodies B, C, and D, they can only bind to one specific virus variant. So it is important so that we achieve a vaccine that's like in that gray vaccine antibody diagram, where you can see that it is effective against multiple different viruses. I haven't shown you any data that they have found to date regarding the initial evaluation of these pan-virus vaccines. What are some of the new vaccines? I'd mentioned earlier that Novovax is asking federal regulators for EUA for its COVID-19 vaccine. Sanofi and GSK are also requesting full approval. They both use older technology than the mRNA vaccines currently use that can hopefully address some of the vaccine hesitancy that we have seen in the desire to receive these vaccines here. The advantage of these vaccines that I mentioned is that they don't need to be stored at extremely low temperatures. Our new vaccines also have to help address the children under the age of 5, for which we don't have any vaccine and remain a vulnerable population. This is the Novovax vaccine design. You see the COVID vaccine DNA, it's COVID DNA inserted into an insect virus, and this is the baculovirus. It has a modified spike protein. It is then entered into cells that are infected. The spike gene creates the mRNA, produces the protein that's then released to the cell surface, and you get the formation of the nanoparticle, and then the nanoparticle is your final vaccine. What else can we do as we move forward? We need to learn from our experience to produce better outcomes. So last week we heard from Dr. Kashyap from his incredible database looking at patients who were hospitalized due to COVID from different areas around the world. And one of the questions that we had asked him last week was, what is one of the take-home messages that you had gotten from this review of your large database? And he had said that there was differential in outcomes of COVID patients based on where they were treated. And what I've shown you here is that hospitals that were dedicated to treating only COVID-19 patients appear to yield better outcome for them than other mixed-use hospitals. And the reason being was the higher use of COVID-19 specific therapies that have been proven in clinical trials. With the information that we've learned, we should be able to have these resources consolidated in certain areas so that we can quickly assemble and quickly provide the best care possible to minimize the morbidity and mortality of any new variants or any new pandemics. We need to continue to repurpose existing therapeutics. Most recently, we found that baricitinib, a drug that's used in rheumatoid arthritis, that when this drug was used in patients with COVID-19, it reduced their risks of dying by 13%. They were able to take other immune modulating medications or other medications such as dexamethasone, and adding this on top of whatever else the doctors are currently prescribing is beneficial. This information was found by the UK recovery trial, and this was published earlier this week. We need to protect, as we move forward from moving from pandemic to endemic stage, we need to protect our immunocompromised and vulnerable populations. We all know somebody who is going through some therapy, whether it be in our own household or someone we know otherwise, who is immunocompromised, whether or not they're getting rheumatological therapies, whether they're getting chemotherapy. And these population, when they get infected, we know that they can have a high viral load and that the virus within them can evolve. We also need to prioritize treatments and preventive interventions for these patients. They need to be included in clinical trials so that we get better information on how to protect this population. We have Ovishield, which is a pre-exposure prophylaxis, which is very difficult to obtain right now, highly prioritized. And it is a combination antibody that was derived from B cells donated by convalescent patients after SARS-CoV-2 virus. We need more of this. We need more drugs like this, and we need it available to more of our at-risk population. Not only for those who are immunocompromised, again, for our children who need to be vaccinated who are under the age of 5, but we also have to address our at-risk communities, those who don't have access to healthcare, those who live in crowded settings, those who have low-wage frontline jobs. We understand those parts of society that were really at risk when this pandemic first began, who didn't have a choice to socially distant, who had to go to work, who went to work in high-risk scenarios. These are the populations that we need to protect. We need to take care of ourselves. We need to take care of our system. We need to be able to continue to provide the routine care, the urgent care, the emergence of any new conditions. What we saw in one survey that was taken recently, that nearly 1 in 5 healthcare workers quit their jobs since the start of the pandemic. And there's a multitude of reasons. A lot of healthcare are women. They had to go home and take care of their children that weren't able to go to school, or they were taking care of someone who was sick. There was a lot of fatigue, mental health stressors, and we are going to face an accentuation of the epidemic of healthcare workers that began even before the pandemic began. We've all experienced extraordinary pressure, and we all felt this commitment to serve sick patients, and we continue to do so. All of that has taken the toll, and we need to be able to recognize and identify and to mitigate the shortages that are occurring now and will anticipate to occur in the future. We need to further expand and support telehealth. This communication technology is available to develop healthcare to our patients, providing the same level of care as those in the physical location as us, whether it be through video chat apps, webcams, phones, or video conference software. We need to make our patients feel comfortable and aware with the process. We can transition use of this also for chronic care management instead of acute care. We can use this and the privacy of patients' home for mental health care. We need to improve user experience. How many of us remember when the pandemic first began and we were all using a beta version of whatever telehealth system we were and having connectivity issues or understanding of how to get onto the web platform? And we need to continue to encourage the use of wearable technologies, whether it be Apple Watches or other wearable technologies for remote patient monitoring. We are still not out of the woods. If we look in January, I showed you earlier a graph of what February 27th and March 3rd looked like. But in January, when schools were largely open, when the New York Times did a survey to see how many missed school days have our children in January missed, what you're seeing is that there's still a significant number of children that missed several days in the month of January. So as we move forward, we cannot underestimate that there are still burdens that are occurring in different parts of our society. We have to be able to make rapid testing and disease surveillance accessible so that our kids can go to school, we can go to work. Currently in the United States, we have 45 antigen tests approved, of which 17 tests that are cleared for at home. We know that the sensitivity of these antigen tests are lower than RT-PCR, but the sensitivity increases if you're symptomatic. And this is really important to identify infection in the early critical transmission period so that we can continue to move forward away from these very strict measures that we have been living through. We have to expand our genomic sequencing. I talked about the sewer surveillance. We know that SARS-CoV-2 can adapt and is unpredictable. We know that variants can continue to emerge. We know that global surveillance efforts can provide clues to changes, and especially to which variants are dangerous. If we had just known 1 week earlier, 2 weeks earlier, what could we have done as a society to proactively take measures so that it didn't affect us as quickly as it did? And we have to develop countermeasures in real time to prioritize vaccine and treatment. We have to continue to fight misinformation. We have to evaluate the source of information, refer to trusted sources, and we need to share on social media after verifying the source. I mean, we can fall victim to misinformation just as much as anyone else. And we also need to be very strong about how we address the loss of trust in the advice of experts, including doctors and scientists. I remember the change in attitudes towards the healthcare providers and physicians at the beginning of the pandemic to later on in the pandemic. We have to continue to make sure that we provide the right science, the right guidance, and we be truthful in terms of how we approach the information that we are sharing. What we are going to see is that the cases and the deaths will continue to decline through spring and summer, but we do not know what will happen after that. Are we going to have a new variant? How is the vaccination and the prior infection or booster immunity going to wane as we move forward into this period away from the Omicron surge? We need to be able to address the availability and the use of Paxlovid and molnupiravir. On March 3rd, the WHO updated guidelines on molnupiravir, and it should be provided to only non-severe COVID-19 patients with the highest risk of hospitalizations who've not received the COVID-19 vaccine, who are older with immunodeficiencies and living with chronic diseases. So we are continuously going to see an evolution of this. And I wanted to end by talking about that we need to see that this pandemic, as we go to endemic, is going to be a part of our everyday life. And we need to learn how to live with this. We need to minimize the disruption on our hospitals, our schools, and our economy. And again, I just need to say that we need to really prioritize our vulnerable populations. Some snapshots of an incredible experience of sharing knowledge on this platform. I feel very humbled and very grateful to have been a part of this forum and sharing information and learning, most importantly, learning from all of you. I want to say thank you.
Thank you, Dr.
For
Monica.
all of what this has shown. Thank you.
Thank you so much. Full presentation and perfect for 100th episode. So everyone in kicks in. Now we are opening the forum for the question answers, and the floor is open. Would you please raise your hands? So I have Dr. Chai from MMA. Please ask your question.
Thank you, Monica. It's an excellent presentation. I've got two questions. One would be when you mentioned about the vaccination for the pediatric age group, you had mentioned that the immunity will last for 150 days. Then the first question which comes to mind would be booster dose. But looking at the way Omicron is behaving, would it obviate the need for a booster dose in pediatric age group? So that's the first question. Number two is you said that the sensitivity of the RTK, the rapid test is about, it's rather low as compared to PCR testing. But looking at the way Omicron is spreading, there are many who are doing away with PCR testing in order to manage the cases of Omicron, to detect the cases. So they are moving over to lateral flow, or rather the rapid test kit in this. What is your opinion on that? Thank you.
Yes, so regarding children and booster doses, what we know is that anybody who's getting their booster dose is going to be protected against severe complications of infection. And the presence and use of booster doses is going to be related to how many cases you have in the area and where the priority of the vaccination is. If you have a patient that gets a booster dose, it'll obviously add to the immunity of that community. I do not feel that the urge is as important today in areas where you have low transmission rates. But as the transmission rates increase, then vaccinations and boosters very, very important. And with regard to the second question and related to antigen testing, I think by making antigen testing available rather than PCR test and knowing an answer right away, I think that others have combat the lower sensitivity of antigen testing by doing repeated tests. They're negative one day, they feel symptomatic, they stay quarantined, they do a test the next day. The information that I gave you came from the Infectious Disease Society of US. And I believe that antigen testing is much better because unless you do a test, it doesn't matter how good a test is. And an antigen test is accessible, it is much more available. And then if you are symptomatic, the sensitivity of the test does go up. And the whole point of the testing is to be able to make sure that you're catching symptomatic people. Thank you.
Thank you. Thank you.
You want to go next? Dr. Jamal Chaudhary, please ask your question.
Everything actually from the very beginning, which he actually have done here. So my question is, I have seen in the US, this Senate, the US president was speaking, and no one was using the mask. Actually, probably this protocol is that everybody is vaccinated, okay, and they think that they are immune, and so they will not contract anything like that because a lot of their what I say, the oldest people and the maybe some sort of this disease also were there. But I feel because of their age and others. So why they are not following that protocol, which you are just suggesting that if you are something like that, having this diseases, diabetes, hypertension like that, which is usually the people are having. So it should be, it should take your own protection. What is the actually, what should be the practice there? Actually, number one. Number two, this is actually giving the vaccines are giving, we are saying from the UK study, it's giving very short-lived immunity. Even if you are boosted, you are getting booster dose. So what the scientists are thinking about this is people are losing actually confidence on these vaccines if it is so short-lived. These two things. Thank you.
Okay, regarding the first question on not wearing masks at the recent State of the Union, as I had shown you earlier, the spread is much, much lower. Hospitalizations have dramatically dropped. My children's school have now mask optional, where from the beginning of the pandemic, they required masks. We're seeing a much better safety level. Every single person that is being convened in any of these mask optional areas have been notified beforehand that this is the environment. So when they're walking into a room with no mask, they know. So if they have personal risk factors that makes them feel that they are at risk for getting the infection, then they have a choice not to go. So that is the answer to the first question. The second question is the faith in the vaccines when knowing that they're short-lived and whether or not they are effective. What we're seeing is that the efficacy of the vaccines are going to change as the virus changes. The known efficacy of the vaccine is before the emergence of a new variant. It's old data that we're applying to a new variant. And then after the variant comes and goes, then we get more information related to the variant. Across the board, it doesn't matter what the variant was or what the vaccination is. We know that vaccination and booster dosing has decreased the morbidity and death rate related to infection. Now, I agree with you. We're at crossroads right now. We have to see, are we now over? Are we in an endemic phase? And we have to see how protective are the vaccines that we have received in each geographic area, what vaccines were available in what country, at what time period, and what are the viral strains that are circulating at that time. But just like you will have a population that whenever a new vaccine comes out, it doesn't matter, they will go and get the vaccine. versus those who are going to be in the middle and they'll say, well, I don't know. You're telling me to get a vaccine every 3 months. It's not working. You told me that I just needed 2 doses. I now need a 3rd dose. Now I need a 4th dose. I think it's going to be a mix and match. For example, Novavax has gone up for EUA in the United States. It's a different platform than the mRNA vaccines. What I anticipate is that Novavax will come out, and when we are trying to use a mix and match approach, I think that those who, when Novavax comes out, may want to get the Novavax as a booster dose, maybe potentially before a big trip over the summer or in the fall when they get their flu vaccine. And we don't know how efficacious that will be now going into it, but it would give them that ability to say that I'm doing the best and I can do whatever I want, because I don't want to go through what I've just gone through in the last 2 years. But I think that the question you ask is going to be something that we have to wait and watch and see. I hope I was able to answer your questions. They were very good.
I'm not getting an answer. Actually, our Prime Minister she's not approachable because she keeps away from all her I think visit of other people. Actually, she's just avoiding it. But when I see the US president is talking in a closed room, air-conditioned room, and he's not wearing mask when he speaks, what does it give the information? What does it give to the people and those people actually those who are running the government and others? That is the thing.
Yeah, he is vaccinated and the cases are very low, right? The equation is changing.
In Bangladesh, actually, it's too low, lower than the US. It's all we are having only 300, 400 cases per day now. Okay, so this situation is there. So what message we can give to her? But yes, it's not nothing to. Is it anything to worry to give this visit to other people or others like that? That is the thing.
That's a decision that needs to be made by leadership based on their comfort level. Yes.
Yep. Thank you. Can we move next? Dr. Muskwa from South Africa. Can you please ask your question?
Thank you so much, Chair. Just thank you so much for the presentation from Monica. Thank you so much. We truly appreciate. I just want to know, I noted in your presentation that it looks like Africa is the least vaccinated, according to your presentation. Do you think that is a threat to the global community? And are there any factors, any studies that have gone to identify the reasons why Africa is the least vaccinated? That's the first one. The second one relates to oh my God, sorry, I got lost track of the second question. I'll come back later. Thanks.
Understandable. The time zone over there is very early. So.
Thank you. Thank you so much for your comments. I did present one of the papers looking at natural immunity, and that was one of my earlier slides in South Africa. And with the immunization level being low, we feel that the herd immunity is quite high in the African nations. Having said that, though, with the emergence of new immunizations, it is possible that immunizations will become available, especially those that don't require the cold chain like the mRNA vaccines. And hopefully with easier access to vaccinations, decreased storage issues, and also coupled with the knowledge that there is a high seropositivity rate in Africa, I do feel that Africa is poised to be protected just as any other area in the world.
Great. Dr. Pillai?
Thank you. At the outset, let me congratulate Monica for the excellent presentation. A good overview, evaluation of the disease and the steps to be taken in the future. Nice presentation. It's very befitting to celebrate the 100th CMAAO weekly COVID update. Excellently done by Saurabh. My only question is, Just like the influenza virus, every year the vaccine is updated, taking into consideration the genetic variations in the virus. So is there any move as far as COVID-19 is concerned to take into consideration the genetic variations that has occurred, a new vaccine which can take care of the variants also? Thank you.
Yes, fantastic question. So I do know that there have been, because the mRNA technology has allowed them to use the variants and to be able to generate vaccines very quickly, that there have been initial studies looking at changes in the vaccinations to address circulating strains. As opposed to what is going to happen in the future, I think that we need to understand whether or not we are going to see another surge of another variant, or if the Omicron variant provided enough community immunity from being so infectious that maybe we are at that beginning of that endemic stage because the Omicron variant was the way it had the properties that it had. If that is the case, we have time, and then we can see what vaccines are available, but it is my prediction and just my speculation that we will see further changes in the immunization as we get another dose, as like we do at the seasonal influenza immunization. But yes, there have been studies that have been looking at this already. What would be ideal is to get that pan-virus vaccination.
Thank you.
Thank you.
Dr. Sajjad?
Okay, thank you very much, Agarwal. Monica, I miss your presentation, but I know your presentation is always very informative and very fantastic. Jamal has asked you. The problem is what we have observed, that the waves one after the other, when the number of cases is going decrease, and then the people are very much relaxed and everything is normal, then next wave is again occur. Do you think that we are going to face the another wave in coming months, number one, or this virus is gradually weaker and weaker in coming months, or by the end of this year, and we will feel and we can meet personally to each other? Secondly, my humble request to all the worthy participants here, particularly Dr. Hedy and Dr. Tai Yong, President of CMAAO, for coming in Karachi, Pakistan for the next CMAAO meeting in Karachi. You all know. So my official invitation, but the CMAAO Secretariat will also inform and invite you all officially. But as a Secretary General, Pakistan Medical Association, I invite you, all of you, please do come and visit Karachi and attend CMAAO meeting in Karachi, Pakistan. Thank you very much.
Thank you.
Doctor.
Dr.
So
Chong. Sorry. Yeah.
Yeah, no, I just wanted to answer his question. Thank you.
Yeah, thank you.
So the question was related to what is the tail of this pandemic going to look like? Are we going to continue to have surges, or are we going to have a slow decline in overall cases? This is a very difficult thing to predict. I think that what we know, as I had said, is that this virus is unpredictable. I would love to think if we have the immunity from Omicron that will help prevent the surge like Omicron was, by having enough immunity to prevent the spread and to help prevent the emergence of variants that are very, very lethal, like the Delta variant was. I do not know. What we do know is that we now have levels of antibodies, even if they're waning. We do have natural infection immunity, even if it is waning. But I do believe that having better surveillance methods and being able to identify any new variants early coupled with the fact that we now have a higher level of global immunized state, whether it be through natural or vaccine, that we are not going to be as affected and the impact is not going to be as great, so that whatever little spikes of surges we have will be endemic and not pandemic.
Can I just have a suggestion to particularly to Dr. Hedy, President WMA, and CMAAO President Dr. Thai Yong, that can you people issue a press release for the honorable the different countries' heads to please follow the SOPs, please wear the mask during their meetings or during their any public meeting, so that the message should be passed to the general public that the coronavirus is not finished, is not completely eradicated. To prevent the spread of this coronavirus, you people should wear masks till the end of the corona. This is my suggestion. If you think that it could be, then please go ahead, please. Thank you.
Before we can move forward, I have Dr. Elvin here. Dr. Elvin, are you still there? Can we have some kind of a situation coming out from Hong Kong? Because I think Hong Kong is one of the regions which is still affected and all the hospitals are still filled up. So if you can quickly give an update. I know you have to leave. You have a clinical meeting right now. Dr. Elvin is the treasurer for CMAAO. Dr. Elvin, right.
Anyway, thank you. Thank you very much, Monica, for your excellent lecture. I hope we could share your viewpoints with our government and authority in our local authorities here, and to fight the battle better. Now, of course, in Hong Kong, we are now at the peak of the pandemic of the Omicron in Hong Kong. So in fact, it all started at the end of December when some viruses, the Omicron strain, had been smuggled into Hong Kong through the border because of the exemption of testing and quarantine of some aircrew members. So thereafter is non-stoppable. And right now we have been using the RAT to test the suspected citizens, and then we won't need to confirm with the PCR test. And so every day there would be more than 50,000 confirmed cases, mostly by the RAT medicine instead of the PCR. And in fact, most of these confirmed cases are mild or asymptomatic, but of course, still there are panicky feelings in the society. And so many people not so ill, and yet they would still rush to the A&E and then overwhelm the medical facilities in Hong Kong. And so you can see the pictures in the headline. And then people would be expected mandatory universal testing in the community and the partial lockdown related to it. And so most citizens, as we had seen before in other countries, would then rush to the supermarkets and the pharmacies to get all the necessary foods and medicine in case there's the lockdown. And so what we had witnessed is that, well, you could say that these are panicky reaction of the citizens, but that is also a genuine concern. If there is a real lockdown and you don't have enough food and medical, all the necessary medicines at home, then of course it's difficult. So I could understand why the citizens would do that. But anyway, so I think this would pass. And I'm quite sure that with the vaccination coverage climbing up to 90% now, we would definitely overcome this pandemic wave. Although, of course, as expected, because the vaccine coverage for the age group over 80 is still less than 50%. And so in the elderly homes, there's more mortality. And so we have over 100 cases succumbing to the Omicron every day now. And sadly, also because there are also the children who are not vaccinated yet adequately. So we had already started the vaccination for the age group of 5 to 11 for almost 1 month. And then we also had started the vaccination for the 3 to 5 years old age group 2 weeks ago. And still, of course, the vaccination coverage in these two age group are not that satisfactory because still many parents are still suspicious, especially they doubt and worry about the mRNA vaccines because this is new technology after all. And just a few months ago, parents had learned that the risk of myocarditis in having the mRNA vaccine in the teenager age group. And so, of course, this had been solved by putting the 1/3 dosage of the vaccine into the thighs instead of the the deltoid, and then also spacing the second dose of the vaccine 3 months from the first instead of the 21 days before. So I think the risk of myocarditis now had been lowered back to as expected in any other age group now. But still, there are many anti-vaxxers in Hong Kong, just as in any Western countries, I guess. So we still have to fight the battle of Omicron in the coming month, I think. However, I myself is confident that we will get over it, although we would expect that the overall population that would be infected by Omicron probably will surpass 1 million, and then the mortality rate will still climb up higher, especially more children could be infected. So thank you very much. So I have to leave now. Thank you so much. And thank you, Monica, for your lovely presentation. And I hope the presentation could be shared in the YouTube later. Thank you. Bye-bye.
Thank you, Alvin. Thoughts are with you in Hong Kong.
Thank you. Thank you. Thank you, Dr. Chong. Bye.
Dr. Chong, we have a few more questions if we can take it. I think we still have Dr. Farah and Dr. Farah, can you ask your question quickly?
Assalamu alaikum. I want to ask Dr. Monica, after an excellent presentation I have heard this morning, the patients who were having regular flu vaccines, should they continue to have flu vaccines along with having COVID vaccinations?
Dr. Farah, that is a great question. As we move away from the pandemic nature of SARS-CoV-2, what we saw as kids were going back to school, that we saw an emergence of RSV we saw an emergence of all the other respiratory viruses that we had seen before the pandemic began. As we were testing our kids with flu-like symptoms, they were being swabbed for multiple viruses, metapneumovirus, parainfluenza A and B, for SARS-CoV-2, for seasonal influenza virus. And what we were seeing is that these children that were getting swabbed were being positive to one, if not multiple viruses, even if they were SARS-CoV-2 negative. It is very important that we address and we prevent other viral infections, because as we move and we are trying to figure out and navigate our ways as we move into endemicity, is that we have to be able to mitigate all the other causes of viruses or some sickness from viruses as well. So if we get the flu shot and we decrease our illness from influenza illness, any viral infection symptoms will not be assumed to be SARS-CoV-2 or ignored to be SARS-CoV-2. So I think it is important, even more so now, that we continue to get and do all the other preventive measures that we do for other viral respiratory infections.
Thanks a lot, Dr. Monica. Thanks a lot.
Thank you. Dr. Muskwa, you have a question, or you just raising your hand before as well? You still have a question?
Yes, yeah, thank you so much, Chair. My last question was regarding misinformation. I think we now all recognize that misinformation has become a pandemic on its own. I was wondering, Monica, if really there is something that can be done by a scientist, whether information, relevant scientific information can be centralized somewhere, some global center of some sort that can be, that is credible, that can, be used as a source of reference by countries when there is this infodemic, as they call it these days. Thank you.
Yeah, so that is a great question. And we do have multiple great bodies. We have the World Medical Association, we have the World Health Organization, we have the NIH, we have the CDC, we have multiple different places where we are getting our information, the WHO. What's hard is that there's so many pieces of information that's coming at so many different times and has a different application to where you are. So the same piece of information will have a different sense of urgency and outcome in terms of policy in one place than it will in another. So I think it is necessary that we continue to all converse, we all continue to talk and decipher through the information. And I think it's up to us as we practice and we work in our local areas to be able to make sure that we have the information across and that we ourselves are looking at the information and not, and making sure that we speak only to the information that is scientifically supported. I think it is very, very easy to get caught up in the new wave and the comments, the preprints, but looking at the solid information, I think what we do know is that this is highly contagious, that we know that surgical masks are better than cloth masks. We know that vaccination boosting is good. We know that if you have access to certain therapies, that it should be done on a risk-benefit ratio and identifying those patients that are triaged to receive those therapies, and that we will continue to need to keep our vigilance high as we decide to move forward. Whether it be we wear a mask all the time and don't stop wearing a mask, as mentioned earlier, or we make decisions to keep everyone safe. But as our comfort level starts to increase, we need to continue to move forward from this pandemic as well, with the knowledge that either we're vaccinated or we're continuing to make choices that are smarter when we have two options in front of us, one that can lead to infection or one that cannot lead to infection.
Thank you. Dr. Monica, a couple of questions which are in the chat and Facebook chat is one, can you comment on the effect of our mRNA vaccine on heart muscles and myocarditis in children? One question is this, and the other one is where if somebody has, like we all know, if somebody has COVID and they are going for a first or the second dose, it gets delayed. what happens if somebody is double vaccinated and going for a booster, and in between they have a COVID again? So how much delay should it be, and does it matter or what?
Okay, so great question. So I put in the chat a link to the CDC recent data related to myocarditis in children. So the big picture is that the risk for myocarditis from SARS-CoV-2 infection is greater than myocarditis risk from the Pfizer vaccine. In the study, or in the information that they presented at that CDC website, they looked at 914 children aged 12 to 17, and myocarditis was found in 47 of these patients. So it is present. When they did find the myocarditis, it was mild, that they were treated with NSAIDs, and that they recovered from this. So like any other medication or vaccination that we discuss with our patients when we look at risk benefits and alternatives to anything that we do, when it comes to the access to vaccinations in kids 12 to 7 in the United States, that is the only vaccination that has received EUA. So the risk and benefit ratio is then based on the information that we know about this vaccine with respect to the risk of infection and getting myocarditis from the infection. I forgot your second question.
About the booster dose and somebody getting infected with the COVID in between?
Great question. So we talked about hybrid immunity, right? And we talked about considering that infection can be considered a booster dose. If you receive therapy for your COVID infection, so whether it be monoclonal antibodies, for example, strontinemab, we then wait 3 months. If you have infection and you recover from the infection, you definitely can receive the next dose, but there's no concern about delaying the dose because the infection itself is providing you immunity. I have seen a very inconsistent approach to getting vaccination, whether it be booster or primary vaccination after infection, ranging anywhere from 2 weeks to 3 months. I look at the patient and I understand, I try to understand what their comorbid conditions are. What I see clinically is a lot of patients with asthma. So if I have a patient who has a COVID infection or a respiratory infection and they're treated with corticosteroids, I will tell them to delay their dose of their booster or the primary vaccination because of the effect of being on systemic corticosteroids. So I think that the answer to that question should be tailored to the individual that is getting that dose.
Thank you. Dr. Chong, would you like to go next? I believe you raised your hands and then you settled down in between.
Saurabh, thank you very much. No, I just wanted to follow up on that waning immunity in children. The paper that was just pre-printed and published by the people in New York and Albany. So that was quite interesting. They found that actually because of the reduced dose in the because of the reduced dose of the Pfizer vaccine, they found that the immunity, the vaccine effectiveness waned quite quickly. So that was just what I wanted to ask Monica about. Any thoughts, Monica?
I agree. So kids' immune systems are evolving, right? They get every infection under the age of 5, and then hopefully they caught it all, so then their immune system is robust for them to start school. And so the immune response to a vaccination that's 1/3 the dose is very different. So if they're close to the age where they can receive the full dose, then obviously then get a booster of the full dose. But I think what's going to happen is that as the numbers go down in spring, we go on vacation, then when it comes to needing a booster, that I'll anticipate that they may need a booster when school starts. Yes. Yes, but in the US, we're riding a wave now where the numbers of cases are going down. So the waning immunity doesn't have as much of a critical need as if we were going into a surge.
Yes. Okay, it's now 1:30, so I think we are almost at the tail end of our slot, time allotted. And I think if there are no other further questions, then I'd like to call a close to this meeting. But prior to that,
do we have the Dr. Tai Yuan so for the closing comments if he's there, and Dr. Veena Agarwal for the closing comments?
Yes.
If he's there, we can at least ask how's the session and taking it forward, how it goes.
Shall we, please?
Dr. Tai, are you there?
Hello?
Okay,
Hello, Dr. Agrell, can you hear me?
Yeah.
Yes.
This is Dr. Brian. On behalf of the Taiyuan Cho, President of Taiyuan Cho, we're really grateful to have to join this conference and learn a lot from Dr. Monica and all the wisdoms from this region. And of course, I will keep following these meetings with the President Cho, and hopefully we can keep this knowledge passing on and have the wisdom to overcome this dreadful virus. Thank you. Thank you very much.
Yeah. Dr. Chong, we have Dr. Veena Agarwal also with us. I just wanted her to join for the 100th session. I think a lot of discussions are happening at her home during the first meeting of COVID. So Dr. Veena Agarwal, are you there?
A very good morning to everybody here from a very lovely venue. This is a park that Dr. KK had adopted in front of our house, and he's converted it into a beautiful piece of, a herbal garden and a medicinal plant garden. And so today there's a little competition, so I'm standing here, which is why I couldn't attend it earlier, but I thought I must at least be here for the concluding part. I want to especially acknowledge Dr. Hedy, Dr. Yon and Dr. Chong. Of course, all of you who've been with us, 100 episodes, my goodness, this is a milestone, and how proud Dr. KK would have been if he had been around. He would have taken it to another level. But very happy to be here when I reflect on the topic for today, looking back to look forward. I think we must all do that. Medically, you've all had very nice discussions and all, but a little bit of life that I have learned is we have to look forward while we look back, because life force is too strong and too beautiful to be ignored. If I look back, this park was full of stones and it had no flowers. I look forward to them blooming now. So there's a ray of hope in everything when we look back and we look forward. What can I say about Dr. Monica? She is following in her uncle's footsteps and keeping the flame alive. All of you who've been a part of this, all these 100 meetings, really kudos and hats off, and a big thank you from my heart and all our family at Heart Care for making this, continuing this flame going, even in the absence of our dear Dr. KK. And of course, Saurabh, there's not enough I can say to appreciate what you're doing. And again, like your uncle, you're carrying the torch forward. So a big thank you to all of you, and all the very best in the future meetings. And thank you so much.
In fact, I think I would want these sessions to go forward in terms of, we've seen a lot of people losing life on an early stage. We've just seen one of the greatest Australian cricketer losing his life at the age of 52. So I think now we should move the medical sessions to the stage where we can give a message to all the countries that how we can live longer and what we can do in terms of staying happy. And I think garden, where she's standing, is one of the efforts which Dr. KK started off with a herbal garden with this.
How can I show the view, Saurabh?
Yeah, absolutely. You can just show the screen. You can just change the camera.
How do I do that? Yeah. So now I have to show it from facing me or just the other way?
The other way. You can just.
Other way. Okay.
Yeah.
Can you see?
Just reverse the camera. Or you can reverse the phone.
I'm
if you
so
just reverse
bad
the
at
phone,
all this.
okay.
Just a second.
Yeah,
now,
just reverse the phone. Yeah.
So this is the rose garden that Dr. KK built, and it's in full bloom now. And then the other flowers, and there's a lotus pond. The lotuses are going to spring bright as soon as the cold wanes a little bit. And what I wanted to show you was this whole park that he has beautifully created with all the herbal plants and medicinal plants. And there is this special plant, which is a guava plant, which we planted here with some of his ashes. So I call this the KK tree, and it's sprouting fresh leaves, and soon there'll be a lot of fruit here. So yes, I'm very proud and very happy in this space that he has left for people to enjoy. And as a legacy, he has left this. So just wanted to share this with you all.
Thank you. Yes, Dr. Chong. So Dr. Sajjad, your hands are raised. Are you asking a question from us?
Yeah. Thank you very much, Agarwal. I just, what Mrs. Agarwal said, I just wanted to say about the KK Agarwal. He was a very good friend of mine. We met so many times during CMAAO meeting. And I also met Mrs. Agarwal in Tokyo also, if she remember.
Of course I do.
Yes, Adab, Bhabi.
Adab.
We must appreciate the effort being made by Dr. KK, particularly for this establishing this meeting every Saturday. We must remember, and we always remember to KK Agarwal. In the end, I must request or through our chairman to present WMA, Dr. Hedy, to just take her view about this meeting.
Absolutely. Dr. Heidi, the meetings cannot be closed without her.
Yes.
You know, I really feel pity. She's waking up early morning and, you know, so thank you.
Well, thank you for inviting me. I am, and I'm very proud. I'm very proud of the medical community and what you have done. And the legacy of KK is very much was a great legacy. We actually had a session here at the Karolinska University Hospital as well, and talked about his work as a role model. So this talk today, Monica, was again excellent, and I'm very happy that you brought up the future of medical need for medical technology, because pandemic or not, we will not be able to provide the same level of medical service in the future if we are not developing healthcare and the way we provide healthcare. We will have big challenges with the workforce and with the pandemic and all the effects, all the heavy work of the healthcare workers. This will be worse. So we really need to develop not only the medical technology and the medications, but the way we organize and provide care. And this platform is typical for that. You built this. You have invented. It was the technology was already there, the platforms, but you have made it big and escalated it, the way we provide information. I would also like to point out what you told about role modeling, wearing face masks as role models, and also that the institutions of the world, like the World Medical Association, WHO, but also the CDC, as an example, will continue to raise the awareness of precautiousness, because it's not over. It will continue just in another form, and we will have other challenges. And we need some very basic guidelines on how to handle the virus and the spread, hand washing or masks, and it must be adapted to the current situation. So it is not over. So, well, I could talk more about this. This concerns me and you a lot, but I'm very humbled to be invited to these meetings. Thank you so much.
We would need a blanket approval for conducting next 1,000 sessions with you and with the chair, permission of the chair of CMAAO and president of CMAAO.
Mm-hmm.
Okay, so Dr. Chong, would you like to close the session with your closing remarks?
Thank you, Saurabh, and thank you, Dr. Heidi Stensmeren, my president, Dr. Tri Yuan from Taiwan, and of course my, my co-chair, Kachai, Saurabh, Monica. What a brilliant presentation, and we always look forward to hearing from you. And it's with a bit of serendipity that we've reached our 100th milestone. We hope to hit our next 125 or 150, and hopefully see this dreaded pandemic come to an end and a close where it'll become endemic. So it's with a bit of mixed feelings today that we close our session. On one hand, the amount of the treasures that we've uncovered with this group of meetings is incredible. I mean, the knowledge that we've gained, the camaraderie, the friendships that we've forged, amazing. So on the other hand, there's always a little bittersweet moments where we realize that Dr. KK Agarwal isn't with us anymore, and he was one who originated all this. So it's kind of with the mixed feelings that I call this session to a close. But yet, let's move forward. Let's look forward to our next few sessions, and let's really, get the show on the road, and look forward to more knowledge, more presentations, more understanding of this great adversary that we have faced over the last 2 years. So I thank you all again for joining us every Saturday.
Just once more, if people want to join, the link and the time remains the same. So you don't have to wait for my message. The session is on Saturday every year, every day, every week. Saturday, same time. And this link is also same. The link doesn't changes. If somebody wants to present on this platform, you can approach me directly.
Thank you, Sarab. And goodbye to all, and I'll see you next week.
Thank you.
Okay, thank you. Bye-bye.